Donor selection and phlebotomy. All right, for donor screening, there are really three processes. You're going to register, you're going to have do a health history interview, and a physical exam. Oh, that's true. If you're on file, they're going to pull your file, but remember, they're still going to confirm full name, address, make sure that enough time has passed, 56 days, okay, and 48 hours after plasmapheresis to donate a unit of whole blood. And then it has to be 8 weeks after to donate a full unit of whole blood. So you should have a driver's license, a social security number. I'm wondering if they have omitted social security numbers with blood donation and given people IDs. They haven't? Okay, okay. Oh, that's right. And they wanted your social security number. Right. And you have to be older than 17. Question. I think if you are 17, they will allow you. If you are 16, you have to have your parents' permission. You can if you have your parents' permission. But if you're 17, you do not. That is where a lot of these blood banks are going to high schools, because if they go to the high school, then they can get all of those potential 17-year-olds. All right. Now, what does allogenic mean? Is species the same species, allogenic? So what you're doing is that particular donation is going to be used by all humans. I was talking to this lady yesterday, and her daughter must be about 55, and she said she had to have a blood transfusion at Indian River Memorial when she had this baby. And she said, my husband had to go find a couple guys that he knew to come in, and she said that the guy was sitting next to her, and they were going from him into her. She goes, the guy was sitting right there, and his blood was flowing into me. That was like 55 years ago. So you know, with the technology that we've gone through, because I said even right after that they were using bottles, and I just shook my head. I said, man, that's crazy when you think about it. But it saved her life during pregnancy. Um, so a directed donation is a donation that is reserved for a specific purpose, meaning if I go in and say, this donation I want to go to this particular person, that is what they will do. A lot of blood banks don't like to do directed donations. Does anybody know why? Well, they do, or they'll put them into the direct, the population, normal population after a period of time. But many people who are asked to do directed donations sometimes are done under duress and arm twisting. And when they go in to answer the questions, maybe they are homosexual, for instance, and they don't want the family to know, but the family's twisting their arm to go in. So they may lie under those circumstances because the family wants them to donate. So they always say that directed donation is not always the safest way to go. You have to think about people and how people react. Autologous, you can do a autologous donation. You have to be in pretty good shape to do an autologous donation, and I can't remember the time between autologous. So they usually take one unit, and then 72 hours later we'll take a second unit, and I believe that's the no, you do it much sooner than that. Yes. And we'll look at, when we do our sheet over here, we'll come back to this. Um, Because you can remember 35, the unit is good for 35 days. Um, and that 35 days you have a window period. But that's where, all right, for autologous donation, blood is not typically drawn more frequently than every 72 hours and not drawn within 72 hours of surgery. And in addition, routine labeling of the blood bag, the patient's name, transfusion facility, unique patient identifier such as the social security number, birth date, hospital number, and a label that says for autologous use only or autologous donor statement must be included. All right. Apheresis donation is when they are taking a specific component, such as parts of whole blood or things such as platelets or plasma, for instance, and then they return the red cells to your body. Now, during the health interview, all of those questions are asked of the donors, and they concern the medications, past, present, medical history, lifestyle, drug history, and remember there are about 50 questions that they ask you. Let me see, in the book they show that there are 32 questions that are asked of the donors, and each of those questions are directed at certain conditions that may or may not defer this person as a donor. Now, what are the permanent deferrals? Hepatitis after age 11, positive HepSag, repeatedly reactive core hepatitis B antibody, present or past infection of hepatitis C, HIV, HTLV 1 and 2, narcotic or alcohol addiction. Remember, some of those questions are directed at this. Or if you have received any kind of pituitary growth hormone, Creutzfeldt-Jakob disease can come from that, and a history of babesiosis or Chagas disease. A 3-year deferral is malaria, and you must be asymptomatic at that period in time. 1-year deferrals are tattoo, greater than 72 hours consecutive correctional institute. So if you've been in jail for 3 days, 1-year deferral. Mucous membrane exposure to blood, exposure to hepatitis, malaria, HIV, hepatitis B immune globulin. Remember, when do they give that? Sometimes to family members, they'll give immune gamma globulin to them. If you've received any kind of blood or blood product, it is a 1-year deferral. I think in the question previously, we were saying 6 months. This says 1 year. So if you've been a recipient of any blood, you have a 1-year deferral. Skin penetration with any kind of sharp. If you at work maybe got a skin puncture with a needle stick, 1 year. Close contact with anybody who's had viral hepatitis. Anybody in your home, say, that had hepatitis B that you were taking care of, you are still deferred for 1 year. Okay, remember the questioning, if they ask you, have you ever been in close contact with somebody with hepatitis B or hepatitis? How long ago? What kind of close contact? Say if you're living with somebody who has active hepatitis B at the time, you will be deferred because you could be in the pre-incubation stages. The questions are designed for those things to come out. All right. traveled to an endemic area where there's malaria, regardless whether you've taken anti-malarial drugs or not, a positive STS or syphilis serological test, and 1 year after treatment. So you can donate, but you must be post 1 year after treatment. Now, 6 weeks postpartum, known pregnancy. Wait a minute, this one doesn't make sense. Is it 6 weeks after birth you can donate? It's only 6 weeks deferral after you've delivered an infant? Pregnancy, so regardless of whether you've had a miscarriage or what, it is 6 weeks past. Question. Yes, there is a minimum weight limit. And I think we have not gone to it yet. I think it's 110. What is it? 110 pounds. All right, temporary deferrals also are if you've been given the rubella vaccine, MMR, or the chickenpox vaccine. Most vaccinations, they defer you 4 weeks, German measles and chickenpox 4 weeks. 2 weeks is the MMR. So the measles, the mumps, 2 weeks. Polio, typhoid, yellow fever is 2 weeks. So as opposed to 4 weeks for the rubella vaccine to 2 weeks for measles and mumps. So when you think about it, though, most of that is combined, measles, mumps, rubella. So you're still 4 weeks deferral. All right, now here's some of the questions that you guys are asking. Remember, you should be in good health. Hemoglobin should be minimum 12.5 grams or 38% hematocrit. Temperature should be less than 99.5 or less than 37.5. Your blood pressure less than 180 systolic. And this one says sky. I always think of saints over devils because the bottom number is usually the worst number. So disystolic of less than 100. That's still on the high side. So you can still donate blood even if your blood pressure is borderline. And I think people come in maybe with a little bit of white coat syndrome too, so they have to keep that blood pressure a little bit high. So pulse should be between 50 and 100. So if you have bradycardia, which is low heart rate, they will reject you. If you have tachycardia, which is high rate, they will defer you. You have to be at least 110 pounds. If your weight is less, they have to reevaluate the amount of blood that is taken out of you. There is a calculation, but they cannot take 525 mLs. They have to take less blood from you, okay? But you can still donate if you are less than 110 pounds. All right, now, what is tested on each unit? Remember, the screening that is done tries to screen for any of these diseases. Now, the tests that will be done are for syphilis, CMV, Chagas disease, and Chagas is a fairly new testing that they've put out there. Hepatitis, HIV 1 and 2, HTLV 1 and 2. They will also do some viral markers. The ALT is still done. At one point they thought maybe they should drop ALT testing, but they found that it is a pretty good indicator of liver inflammation for whatever reason, and it is a good reason to reject donors. Now, any kind of inflammation of the liver that can be caused by bacteria, drugs, alcohol, toxins, viruses, any kind of disease of the liver has the highest amount of transmission rates. We know too that even certain bacteria that like the cold can also grow in those units. Maybe somebody who's had a bacterial infection. Do you guys remember the cold organism? Yersinia? Yeah, there you go. Yersinia enterocolitica. There are people that end up with like a mild form of diarrhea. During the interview process, you are asked, have you not felt well? Have you had diarrhea? Those are to reject those kind of donors that could intermittently have bacteremia, and that all it is that one or two little bacteria. If it gets into that cold blood, Yersinia loves the cold. We have a question. How come some venereal diseases? All right, why not gonorrhea? Why syphilis? And CMV? Now, because those particular diseases have been documented as being transfusion-related diseases. So if they only have one time that they can document a disease being transmitted in blood, then they have to test for it. That's how the federal government works. All right? So when you think of how gonorrhea is an organism that is pretty susceptible to its environment. So even if somebody came in, if they had bacteremia with gonorrhea, and of course I'm just making assumptions here, I'm going to assume that refrigerating that blood is going to kill that organism, just the refrigeration process. All right. CMV does not. You can still transmit CMV in blood units. And many times you want a CMV antibody negative patient to donate to infants because CMV has been documented to be transmitted. And where is it going to cause a problem? In infants, in fetus, in very young people. Most adult donors are CMV positive. So when you get that one CMV negative, now we're talking antibody here, person, that person is set aside because then it's like, okay, this one can be directed towards infants. And then they'll say, this is a CMV negative unit. All right, now we know that hepatitis A is not tested for because it's fecal oral. B is transmitted. C can be transmitted the same way as B. D we do not test for, but it is known to piggyback along with B. And E is not tested for because it is also fecal oral. So it is not known to cause transmission in blood and body fluids. Now, hepatitis testing, HepSag, is routinely done. And remember, if you are positive for the vaccine, you will not have HepSag. You're going to have the antibody to HepSag. All right? But HepSag means that you have the virus. You are actually infected. You have active disease. They also test you for the antibody to the core. If you have the core antibody, that is a rejection because you have had hepatitis. ALT, if your level of ALT is high, it's saying that you have liver inflammation, and a good possibility you have hepatitis C. When we think back of pre-hepatitis C testing, when a patient came up with an elevated ALT, they were rejected as a donor, and many of those patients were told that a good possibility they had hepatitis C. Now we can actually test for hepatitis C under those circumstances. And that should be presence, test for presence of hepatitis C using PCR testing. So we are using nucleic acid testing for presence of the actual hepatitis C virus. Now, we're also testing for HIV 1 and 2. 1 is more common in the U.S. and 2 is more common in Africa, but they are both spread by sexual transmission, perinatal, breastfeeding, peritoneal, this word I have a terrible time, parenteral, is that right? Parenteral exposure, meaning inoculation, blood body fluid injection, okay? Now, testing for antibody to HIV 1 and 2 is done routinely to screen for donor blood. Western blot is done for confirmatory testing. Do we have a question? What's the difference between HIV 1 and HIV 2? They are just different serological types. It is both, they both cause AIDS, but one is more prevalent in Africa. But we are seeing people coming from Africa with the HIV 2 strain that are, need to be screened as blood donors or coming into the blood donor system. So that's why they are testing for it. Now, the look-back process is a process where identification of looking back at donors who tested positive. The look-back system was done early in the late 80s when we first discovered HIV being in the blood system. So what they did was they looked back, because they keep all of those units frozen, so they had an accurate way to test them. They tested all of those past units for HIV. Then anybody who was given an HIV positive unit were contacted. Now, I have to tell you, I worked in a blood bank when this occurred, and we did have patients that were given HIV positive units. Luckily, most of those patients were near the end stages of their disease and ended up dying because of their disease and not because they were exposed to HIV. But there were patients in this look-back system that were given AIDS from a blood transfusion because it wasn't tested. So you have to remember how the FDA works. If anybody gets any kind of disease from a blood product, it must be tested. So that's how originally then HIV was tested. Now, syphilis is, remember, the most common transmission is sexual. The RPR, or rapid plasma reagent test, is a common test being done for this. Hemagglutination test is also being done doing microtiter techniques. This can be automated, so at some of the big blood centers, that's what they're doing. They're doing a hemagglutination test to detect any kind of antibody for Treponema pallidum. So remember that they're foregoing the RPR test, and they're testing for specific antibodies to T. pallidum. If you test up positive then you do have antibodies towards syphilis, and you do have syphilis. And maybe you had syphilis in a younger age, and you need to be re-dosed with penicillin or whatever treatment because the first treatment didn't work. ABO and RH testing are also done, and antibody screening is done to determine if you have any unexpected blood group antibodies for the plasma, because remember, you're going to break these units into components. That plasma can be given to a donor, and you want to make sure that you're not giving that donor antibodies to a antigen that he has. Some of the other tests, of course, CMV we just talked about previously. Chagas disease. Chagas disease now is getting to be transfusion related, and one of the problems with Chagas, as we talked about in parasitology, is it is not responding to treatments. So it's becoming a very serious, prevalent ailment, and as our donation pool, especially in the Florida area, in South Florida, we see a lot of people from a lot of different countries coming to Florida. So you're going to see some people who may inadvertently go to donate blood and have Chagas disease. All right, let's talk about some of the blood component prep and the therapy. Now, whole blood, remember, is what is collected from a donor before it is separated into its components. Have all of you donated blood at least once? Has anybody in here never well, some of you, if you're not big enough or your hemoglobin is not high enough, you're not going to donate. But the whole donation process, if you look at the bag of blood that they take, it's big. It's much bigger than what the packed cells are that you're routinely taking out of the blood bank to cross-match blood to, all right, or preparing for the handing out to a donor. Remember, that is about half of the total volume that they're taking from you. All right, so those components it is actually centrifuged, and during the centrifugation process, they can take off cryo, they can also take off platelets, and then they can also take off the fresh frozen or the plasma. All right, most of the time, most patients need the red blood cells. All right, because most of them need what they say is chemotherapy. They are lacking the red cells for oxygen. They have oxygen depletion. Now, the primary bag contains an anticoagulant, and then what happens is once they draw the blood, they then mix it in this primary bag. Now, what I saw now, has anybody donated? I haven't donated recently, but they have another little like capture bag that they donate some of that first. And the idea with that small bag, or they're actually taking tubes of blood to test, is the skin plug. I didn't realize this because they use such a big needle that when they stick that in you, you actually have a little piece of skin that is pulled into that blood bag. So potentially that skin could have bacteria on it. I just never thought about that, and when I sat in this one lecture, they said that plug has the potential to cause bacterial contamination to that unit. So now I notice they actually have one little bag that a first amount of blood goes in there. Now remember, what happens over time as that unit is stored, that the red cell function goes down, all right, as it's stored. The plasma hemoglobin, plasma potassium increase, and the viability of those cells go down. So the purpose to preserve and the preservative is to keep the cells viable over approximately 35 days. Now, in my first days of blood banking, 28 days. It was 28 days. Now they've come out with CPD-1, and it keeps those red cells viable for 35 days. They can also add additives that will keep the viability up to 42 days. Now, I don't know if routinely they're adding these. Does anybody know this? If routinely, usually it's 35 days for the unit of blood, not 42, right? They're not adding Adsol, Nutricel, or Optisol to a normal unit, or do they? So they are adding AS1 to give you a total of a 42-day expiration. All right, we'll go through this when we look at the label and look at the type of preservative, because remember, the amount of days that a unit is viable depends on its additive. You must add this additive to the cells within 72 hours. So if you're using CPD or CPDA, when you are actually collecting the blood as an anticoagulant, you have to add the other additives within 72 hours in order to keep it viable for a longer day. All right, so separation of the blood components. You have to have the satellite bags. You use a centrifuge. The plasma then is expressed off usually with platelets in the first bags, and then the additive is added to the red cells after you have the platelets and the plasma taken off. Then your platelets are sealed. If you're taking platelets off, your cryo is frozen and your plasma is frozen. So let's talk about storage. Storage of whole blood anywhere from 1 to 6. Okay, remember, storage is 1 to 6. Shipping is 1 to 10 degrees. For how long? How long can you keep it in transit 1 to 10 degrees? There's got to be a limit to the time. 24 hours, okay? So addition of the adenine, which is what we were saying, increases the shelf life. Each unit of whole blood will yield 80 units of cryoprecipitate, AHF. 35 days if it's collected in CPDA. Remember that most of the time we don't use whole blood anymore. When would you use a whole blood transfusion? Well, but we don't even have it on the shelf. Most blood banks don't have whole blood. Not even autologous. Autologous donations, they take the plasma off. They're not going to give you whole blood. Anybody know? How about exchange transfusion for an infant? That's the only one that I can actually think. Now, in old times, yes, we would give whole blood if you had somebody who was in a car accident or massive transfusion. But because it's not available anymore, they would give packed cells with fresh frozen support if the patient needed that. Why don't they give you back your own plasma? Because most of the time you don't need the volume as much as you need the red cells. See, you have to look at how the chemotherapy is being done, because you want to add red cells and not plasma. And I know it makes sense to say, well, if it's my blood, just give me it all back. But you have to think of during a surgical procedure, they're also giving you fluid by other means, and that counts as volume. So I don't think they think that there is, they would rather give you 2 units of more cells than volume at that particular moment in time. So if you give 1 unit of whole blood, it should increase that patient's hemoglobin by 1 gram, or the hematocrit by 33%. Okay, 3%. Now, red cells, the storage temperature 1 to 6, shipping 1 to 10 degrees, once again for 24 hours. Now, RBCs, they add the AS1 after they separate it to give you a shelf life of 42 days. So it is 42 days from the day it was donated. Now, if you freeze red blood cells, you've got to have them at -80, and they are good for 10 years. Okay, so maximum condition is -65. -65 to -80, or so it should be -80 to -65. Yes, it is. So it should say minimum, right? This is not correct. All right. Now, when do you use frozen blood? Frozen blood is not used routinely, but when you think about, and this says sickle cell disease, why are you using it for patients with sickle cell? Because they develop multiple antibodies. These people have multiple transfusions over their lifetime. They develop multiple antibodies, so you have to find a suitable donor. So if you find donors that are negative for a lot of different antigens, then you freeze the blood. Now, if you ever go to one of these big blood banks, you'll see that they are testing donor units for a huge number of antigens. And you scratch your head and go, well, why are you testing all of those units for all of these particular antigens? And they'll tell you, because we're looking for unusual donors. And that one unusual donor, then they pull out of the system. Then you're on their phone call, because if you're an unusual donor, every 56 days they're going to say, hey, could you come down and donate some blood? And they're either freezing your blood, or they're using it for one particular person. They do antigen testing. They don't, now it is not, you don't have to do it by FDA standards, but they're looking for unusual donors. And when I went in to watch how they did all of this, I was perplexed. I said, why do you do that? And they said, well, we're looking for donors, unusual donors, because we need those donors for somebody, say, who has sickle cell with multiple antibodies, or somebody who's had multiple transfusions over a period of their life and have developed these antibodies. So, there are very few units of blood that are going to be compatible to them. Now, leukocyte reduced red blood cells, the leukocytes are taken out. Now, you can do that by a variety of means. You can wash the unit, you can irradiate the unit, but what it does is it's going to reduce your danger of transfusion-related CMV, because CMV is in the white cells. So if you happen to be an immunocompromised donor, you want irradiated. Remember, any of your leukemia or cancer patients that are on chemotherapy, that physician is going to ask for irradiated blood. Why? Because he wants to make sure you don't have white cells in that blood that could cause a possible HLA reaction or have virus such as CMV. Now, once you defreeze that blood, remember it has glycerol in it, so you have to thaw it, and then what are you going to do? You have to wash with saline to get the glycerol out. You don't want to put glycerol back in the patient. You have to wash all of that glycerol out. So have you guys seen how they freeze this blood? They are in like these sheets. They're big. The unit is like this big, and they're in these flat, frozen areas. And then they pull. Actually, I think Holmes didn't. No, I didn't take you guys to Holmes. You're the one group that I didn't. I think they had some frozen blood there, and then what they do is they pull it out, and you take the unit out. You put it in 37 degrees water bath, and once it's thawed, you have to be careful with thawing it because you got red cells there. Then you have to have a cell washer that actually washes the unit. Now remember, once you do that, that unit has to be used, and that unit has to be transfused within 24 hours. It's considered an open unit. All right, just like plasma, once you thaw plasma, how long does it last? 24 hours. It has to be infused. You want to then make sure after you've washed this unit to keep it from 1 to 6 degrees when you get it done. So you're storing it as you would regular blood units. Now, irradiated, it has a shelf life of 28 days. And I think that's why they don't irradiate all blood products, because it does reduce the shelf age. We know storage 1 to 6. It is to reduce any kind of graft versus host, HLA type of reaction, people that are on chemotherapy, premature infants, as I said before. Now, platelets. Here's the thing with platelets. Each unit should have, and we're talking about a random donor unit, 5.8 times 10 to the 10 per unit. Now, they should be stored at room temperature, and they should be agitated. They are good for 5 days. The first 2 days is spent in the blood bank being screened. This is a fairly new practice because platelets have been known to transmit bacteria. So in those first 2 days, and because it's a room temperature product, they have to be cultured and have a negative screen before they can be given to the patient. So you're talking only maybe a 3-day window to be given to the patient. Once you pool platelets, they expire in 4 hours. And these, single donor platelet units, you don't see very often anymore, because they are doing now platelet pheresis, and most patients do better with platelets coming from one donor. Because think of why your patient is having to actually have a platelet donation to begin with. Okay, fresh frozen plasma, or FFP, it is good for 1 year once you've frozen it, minus 18 or colder, and your whole blood is separated, your plasma is taken off by centrifugation, and then they freeze the plasma within 8 hours. Now, what do you use FFP for? So, clotting factors, not platelets, clotting factors. So, if you have a patient that maybe has an extended PT, okay, or you have a patient that may have an extended PTT, you can give plasma to try to reduce the INR. Say if you had a patient that overdosed on Coumadin, is actively bleeding, plasma would be the better choice to give that patient. All right, now once you thaw this, whether you're using a water bath with the port covered, and we now make sure that the port is covered because we were throwing these units into a water bath at 37 degrees that was loaded with bacteria. The port was contaminated, and then the nurse went in and stuck the thing into the port, and guess what? The patient was being infused with that bacteria from our 37 degrees water bath. So if you use a water bath, always cover the port, because if that is your plan B, because your microwave thawing unit is broken, make sure you always cover the port. You should give ABO compatible with the recipient cells. All right. So if you have an A patient, what type of plasma can you give them? An A or AB? Okay. So AB is the universal donor for plasma. All right, so think about, okay, what is in the plasma? Remember, an O has anti-A and anti-B. You don't want to give a unit of O plasma to an A patient. How about if you're B? What can you get? B or an AB? How about if you're an O? What can you get? So you can get AB, all right, or you can get O. All right, so think about, what is in this plasma? Write it down. If you need some visuals, write it down. All right, platelet pheresis. Now, here's the answer to that question. And it says 75% of all platelet pheresis units tested shall contain 3.0 times 10 to the 11th. So that question, it was wrong. See? Hey, you're going to remember that one. So 75% should be, and that said 5.5 times 10 to the 10. 5.5 times 10 to the 10 is lower than 3.0 times 10 to the 11th. Right. Pooled platelets, right, for every unit. So it's different. So this is platelet pheresis, and you can see there is lower numbers of platelets. We'll have to look that one up and see for pooled. But it says, it doesn't say how many units, though. This says 5.8 times 10 to the 10, but it doesn't say for all units tested. This is random donor. So I would assume it has to be for all, because if you're taking these units off, they're going to have to meet this criteria. So that question was correct in the way that it was given to you. Okay? All right, now cryoprecipitate is given, if you have a patient coming in, say, with factor VIII deficiency, hemophiliac, they also use cryo for surgical glue. Did you guys know that? So you can actually have units in your blood bank freezer, and then during a surgical procedure, if they need it for glue, the physician actually takes it off. There's only a little tiny amount in there, maybe 3 cc's, 4 cc's, maybe 5 cc's total. And then he takes it out and actually does a topical, like internal lavage kind of. He just injects it on the area that he wants fibrin to adhere for cryo. Now, they expire in 1 year just like plasma. They must be -18, used to treat von Willebrand's and many times factor VIII. Much more commonly, factor VIII people are taking factor VIII actual factor now. It is a factor concentrate that is now not derived from humans, so you cannot get bloodborne pathogens. So now once you thaw this and pool them, it is only good 4 hours. Remember, when you pool something, 4 hours. If you thaw and do not pool, 24 hours. Okay? You want to then make sure that you keep this 1 to 6 after you thaw it.